Welcome to tonight's CE webinar on understanding the Magnetix design technology. My name is Greg Essenmacher, and I'm the Senior Director of Business Development here at 3D Diagnostics. This is the third in a series of 3 with 3D Diagnostics prepared for Guardian Dentistry partners. Previous episodes are available on demand through our YouTube channel and from Kim Grensevich, your partner for everything education at GDP. If you do have any questions during tonight's program, feel free to put that in the Q&A box, and those will be handled tonight through during the program, and also there'll be time at the end by Dr. Safwat and Dr. Barakat. Tonight's presenters are Dr. Hisham Barakat. Dr. Barakat is the Chief Clinical Officer and a partner at Guardian Dentistry, a diplomat of the American Board of Oral Implantology and fellow of the AAID. He maintains his private practice in Vienna, Virginia. Dr. Barakat supports over 60 partners at GDP and enjoys mentoring the associate doctors across Guardian's network. And from the 3DDX team, Dr. Ahmed Safwat. Dr. Safwat is a senior clinical director and has been working with 3DDX since March 2017, where he's been a member of the treatment planning department, quality control team, and research and development team. Without further ado, I give you Dr. Ahmed Safwat and Dr. Hisham Barakat. Welcome, gentlemen.
Thank you, Greg, for the introduction, Dr. Safwat. Before you get started, I wanted to thank you and thank 3DDX and Greg, of course, for your kindness and your extra, effort trying to bring our doctors together to educate them and walk them through the different modules and the different techniques to better their practices and their implant practice. I know this is a lot of effort and preparation from your end, and we really appreciate it, and can't wait to learn everything. So please, teach us, help us understand, and make us better clinicians. Thank you for making the time and putting this together.
Thank you, Dr. Barakat. I cannot wait to share with you all our Magnetix design technology today. So thanks, Greg, as well for the great introduction. So today we'll focus on the journey of development of such a unique product, and we'll also get to know how to prepare for a Magnetix case and then to how to execute it most efficiently. But let's get back in time to the process of starting the Stackable Guides. So the main theme of a stackable guide is just a set of surgical guides or components that are assembled on each other based on a common foundation, and that piece remains inside the patient's mouth, fixed using lateral fixation pins or anchor screws. Before we launched Magnetix, we reached to the vertical retention keys design, the one on the bottom left right there. We also had several other designs like the horizontal retention keys, and also we tried some fancy designs like the semicircle stops. If we look further into the vertical retention keys design, now you're going to find the top part, which is the implant surgical guide. It used to be printed along with its retention keys, and this was a delicate design that needed a high-end 3D printer in order to print this properly, because these little retention keys would need a quarter turn in order to close or open them in order to secure the top part or remove it from the foundation guide. While the horizontal retention keys is a simpler design, as you notice here, the implant surgical guide printed and colored in blue, the bone reduction guide is the one in white, and then there are female holes in both the top component and the foundation component, where you can assemble a 3D printed key from the facial aspect to lock both together. When it comes to the semicircle stop design, now you can gain support only from attaching the top part to the bottom foundation part, either by resting on the fixation pin legs or on additional rods like these. But you can imagine that these are a bit fragile. If you exert more effort in them, they could break, or they could render the guide useless, in fact. So after collecting all the doctor's feedback and referring to our research and development team, now safety comes first. Imagine you doing a surgery and one of these little pieces fall inside the patient's mouth or gets swallowed by the patient. This is a very unpleasant scenario. We wanted to avoid this from happening by eliminating any external parts from the equation. Also, I guess if we ask a question, what's the most valuable asset in your practice? I believe we all would agree it's time. So being able to achieve the same surgical procedure throughout less time was one of our biggest concerns here. And when digital was first introduced into the dental world or guided surgery, we think about fast, easy, but also accurate. So accuracy played a big role in our beta testing for this new design and new technology. And people also wanted to use something that's easy, something that's intuitive. You don't have to think whether the lock is open or closed, especially in a bloody field. It's very hard to tell whether this little piece of plastic is in the right open direction or closed direction. And allow me to introduce you to our design. So this is a snippet video of the Magnetix, just showing how easy it goes in. It snaps in place. And let me just show you that video. Again, it drops right in, and you can easily remove it intentionally whenever you need throughout the surgery. Before, you needed to unlock all the keys in order to remove it, but now just whenever you need, just remove the guide and proceed with whatever you want to do. But before we get started with the Magnetix design, let's have a quick refresher on what are the necessary data you need to send to 3DDX in order to complete a Magnetix case. Let's start with the CVCT. So there are many questions when it comes to the CVCT. What's the best slice thickness? Do I need to separate the tissues or not? Will my patient have to bite, or should I take this CVCT with the teeth out of occlusion? What's the best field of view? Let's cover each at a time. So a slice thickness that's recommended for guided surgery falls in the range of 0.2 millimeters to 0.4 millimeters. Anything within this range should be very acceptable for guided surgery planning. And I want to emphasize on the importance of soft tissue separation. And by tissue separation here, we mean separating the cheeks and lips from the rich soft tissue. This increases the scan quality dramatically and also enables us to have a better matching for your models on top of the CVCT scan in case there are any metal artifacts. We could then trace the soft tissue outline and have a better confirmation of the model matching to the CVCT again. When it comes to the field of view, now this is a matter of preference and a matter of actually it's corresponding to which arch you're planning to restore. If you're planning to restore the upper arch, now you have to cover the sinuses, the upper arch, together with at least 5 millimeters of the opposing arch. While if you're planning for a lower arch case, it's recommended to include the inferior border of the mandible, the crest of the ridge, and any teeth that are present on the lower arch, together with 5 millimeters of the upper arch teeth or denture. For all partially edentulous cases, 3DDX recommends that you scan your patients out of occlusion by simply putting 2 cotton rolls at the bicuspid region on each side should be good enough for separating the upper and lower dentition while taking the CVCT scan. While for patients who are edentulous and you're going to use the dual scan method, it is actually recommended to take the CVCT while the patient is wearing the denture and whether biting directly on the opposing arch, dentition, or denture, or it's better also to use a PVS bite registration material as an index for the denture of the arch of interest to the opposing. This bite registration material will work in our favor in order to secure the denture in place and avoid any gaps. And let me speak a bit more about the scanning of the separate scanning appliance for the dual scan. So you got to start with a scanning appliance, whether the patient has a denture, so you got to reline it first, or if the patient does not have a denture, you'll need to reach to a point where you at least have denture base with occlusion rims, or even a tri-in denture to be able to plan the case restoratively driven according to the teeth, shape, anatomy, and alignment. Once you have that scanning appliance in hand, you will then need 4 to 6 markers on the facial aspect and same on the lingual or the palatal aspect. Please make sure to place them away from the teeth. You can get these short marks online, or you can purchase them through 3DDX. And once you assemble all this together, you will take a separate CVCT scan for the denture by itself. Make sure to put it on styrofoam or something that makes it float in air during taking the CVCT. And then the second scan would be the patient scan wearing that denture. That same denture with the same markers are going to be used to stitch both scans together, and this would be the final product. From then, we can proceed with our restorative-driven implant planning. Always remember that the fit of the scanning appliance to the soft tissue while scanning cannot be surpassed when it comes to the fit of the surgical guides. So please make sure to double check the scan quality, go over the scan cross sections, and make sure it's completely avoiding any voids of air between the denture intaglio and the patient's soft tissue. Number 3 would be the impressions or models or intraoral scan. We work with PVS impressions, and we recommend either sending a putty with a wash, a PVS impression. Remember the best orthodontic impression you took and try to replicate that in means of going to high enough in the vestibule and also covering all the dentition and the arch of interest. And when it comes to using intraoral scans, now we all understand that it's a bit tricky for full arch scans, especially if there are any dentulous areas. So make sure to follow a continuous scanning technique in order to provide 3DDX with the best scan quality. Always make sure to double check the scan quality yourself before sending it over and even before sending the patient home. Number 4 would be the photos. Photos are not really required if you're not planning to restore the case immediately or if you're not ordering a restoration from 3DDX, but they come a long way in terms of planning the case and also double checking the verification of the patient's occlusion. This is our reference for the photos that you should enclose with your guided full mouth restoration order. So we need 3 extraoral photos, 1 from a lateral view, and this is most significant when we're dealing with a class 2 or a class 3 patient, especially if it's very significant. 1 anterior view with a still or with a social smile. And the third one would be with an exaggerated smile in order to help us determine the transition line, especially in bone reduction cases. For intraoral photos, we need 2 occlusal shots, 1 anterior shot, and 2 lateral shots at the maximum intercuspation. Now, are all the models the same when you send us the case? I believe not. So for cases with stable occlusion, you'll only need to send us the arch of interest with the antagonist and the bite registration at correct video, whether this is in a digital format or a physical format. And for class 1 partially edentulous patients or any case without stable occlusal stops, you will need to send us, of course, the arch of interest, antagonist, but you'll have to enclose a wax occlusion rim or a wax occlusion rim intraoral scan together with the bite registration at the correct video. For any fully edentulous case, please make sure to use the dual scan method as it's the gold standard for these cases. And you will need to send us 3 impressions as well. The denture outer surface, there is no need for the intaglio as the intaglio will be captured from the dual scan as we mentioned before. The antagonist arch or the antagonist denture, whatever is present on the opposing arch, and also the bite registration at the correct video. And for any rehabilitation cases that would involve video adjustments, please make sure to send us a bite registration at the desired video. When it comes to ordering a backup complete removable denture, please make sure to send us physical and not digital impressions. Full vestibular depth is recommended, together with a full coverage for the support areas. Number 5, face scans. Now, those days are gone. We're used to have a complex face scanner. Now there are many mobile applications that help you achieve a good face scan. And face scans, along with the photos, will not only help us to generate a virtual patient for your planning, but also will help us design your patient's teeth to whatever fits their face. So as an example here, we have a muscular patient, male patient, and as you notice, this was transcribed into our digital wax-up by having more flat teeth and more angular zenith angles. But this patient has more round of a face, so we used our digital smile design in order to design her teeth with curved indentations and curved embracers, as you can see right there. Now, this was just a refresher when it comes to the required data for starting a Magnetix case. Please make sure to get back to our YouTube channel for part 1 and part 2, where Dr. Shadi Hassan shared with us a very great introduction to surgical guides, implant case planning, all the required data, the do's and don'ts with the scanning procedures. And also in part number 2, he showcased a live quadrant case planning and a full arch case planning. Now, I would like to stop here and ask everyone if we have any questions. Dr. Barakat.
I'm sure somebody will if you want to elaborate a little bit more on the face scanners, what's an app or the best way to do that?
Well, let me double check with the apps. I'm going to get back to you by the end of this presentation, if you don't mind.
Okay. Just to give you guys all the records you need, we want if you can just give us some feedback on what's the best way to do the face scan, that would be great.
Sure thing. I'll make sure to get back to you with that. If not through the presentation, so maybe after.
No
Don't
worries.
worry about it. Yep.
Thank you. Any other questions? I don't see anything in the chat box. I think.
Yeah, one of them is OB Scanner. I have my restorative team helping me out here.
Okay.
OBI Scanner.
Okay, I'll look that up.
Yep. So let's go ahead and proceed, and let's get started with our Magnetix guides designs. So this is our Magnetix guide, and as you notice here, the surgical guide foundation piece is fixed inside the patient's mouth with the lateral fixation pins, same as any stackable guide, while the top part will be assembled to the foundation with the magnets, which would retain the guide in place. So this is featuring these FDA-approved coating material magnets. They are unique, truly unique in the market. You wouldn't find them anywhere else than 3DDX. And don't worry, they're not going to fall off, but just in case, they are FDA-approved. They are totally enclosed inside the surgical guide. As you noticed through that snippet video, the guide assembly is very user-friendly, very intuitive, and this allows for a predictable implant placement. Now, usually when you receive a Magnetix case, there might be a part that's called the flap guide, but it's not necessary or it's not mandatory. But any Magnetix case cannot go out from 3DDX towards your side without having a pin positioning guide, or the PPG. And there are two ways to do it. Either the regular PPG, and we're going to speak about this in a minute, but I want to focus more on the Magnetix PPG. And for this, we have 4 types available right now. Either a teeth-supported PPG, bone-supported, denture-like bone-supported, or teeth and bone-supported. Now let's get in depth and take a look at these from the cross sections and from the planning software. This is the teeth Magnetix PPG. And as you notice here, the top part is resting on the teeth, and it's also assembled to the bone reduction guide with the same magnets. The beauty of this design is that it goes in, you will be drilling one time and pinning in the bone reduction guide, and that's it. You will then remove the top part that was resting on the teeth, commence with your extractions as usual, bone reduction, and then you'll be proceeding with the implant surgical guide and the restoration if you ordered one. This is a bone-supported Magnetix PPG. So the only difference is with the top part, where this patient is completely edentulous, or in some cases where we don't have a reliable model registration and maybe a couple of teeth only that are present. So we would agree with the doctor that it would be best to extract these teeth and proceed with a Magnetix bone-supported PPG. The third type is a combination of teeth and bone. So sometimes we have only teeth available from cuspid to cuspid, and we're doing reduction down to the first molar or even beyond that. So we use that distal free and saddle region in order to support our Magnetix teeth/bone pin positioning guide. This is also useful in cases where we have a big span of edentulous area in the anterior region, like if you have cuspid to cuspid missing. We can then use the anterior region for bone support, make the best use of the teeth for teeth support, and this way we can avoid any rocking or reciprocation for the surgical guides. The fourth type will be the denture-like bone PPG, and this offers best of both worlds. So you'll be gaining a positive seat through the intaglio of this top part being seated on the available crestal bone before reduction, of course. And then the outer surface of this PPG will be the same as the occlusion anatomy or the teeth anatomy on your denture. So you can actually have the patient bite, whether directly on the opposing teeth or on a bite registration material, to have a bifixation for these two pieces all together. You will commence with preparing the fixation osteotomies. Once you drill one of them, you'll be pinning it right away. And after you finish pinning all four, you'll remove the top part, start with your bone reduction, and go from there. Now, the regular PPG, we have 6 types: teeth, mucosa, denture-like, mucosa-supported, denture-like, bone-supported, a bone-supported regular PPG, and also a teeth and bone-supported PPG. Let me walk you through an old design which used the regular PPGs. So this one on the top right there is the regular separate PPG part. This, by the way, is the flap guide. It only marks your distal extensions of the flap for doctors who would like some help to what extent should I open my flap. And as a general rule, more is better. So please be generous with your flap elevation, and always make sure that your flap is well reflected away from any of the surgical guides, intaglio or flanges. And this would be our Magnetix teeth PPG in action. There we go. They go in as one piece while the teeth is still in there. And you want to make sure to open your flap first before extractions and before bone reduction. The reason why we say that, it's not only because of the guide design, but it's actually a biological concern. So when the teeth are still there, your flap elevation would be more resistant to tearing any of the thin facial plate support. Imagine if you extract the teeth first and then try to open your flap, any little piece of unsupported bone will be easily broken, which will change the anatomy of your fitting surface. The next part would be the Magnetix base or the bone reduction guide. So this is it. It will have the bone sticking out of it for you to reduce it using any of your recommended or any of your preferred burrs or rongeur first to start with the gross reduction and then finish it off with a football burr. And then goes the implant surgical guide. And when we speak about the implant surgical guide, there are actually 4 types of it. You can proceed with a pilot drill guide or a pilot long stop drill guide. Both will look the same, where your implant surgical guide is going to be sleeved with only a very small sleeve accommodating one of your pilot drills. And this can be either the manufacturer pilot drill or the regular pilot drill, doesn't have to be guided. And accordingly, this will provide you with two parameters of guidance only: positioning and inclination. Some regular drills or some guided drills like this one by Nobel would have visual markings only without any physical stops. And you can use type 2 surgical guide, which is a pilot long stop drill, by purchasing one of the 3DDX pilot LSDs, which will give you also depth control. And then after using the pilot drill, you'll have to remove these guides and proceed with freehand preparation, widening for the osteotomies, and then freehand implant placement. Type 3 would be a guided drilling sequence implant surgical guide. And as we can see here, this one was planned with a 3DDX guided kit, which features a side opening sleeve on the two distally inclined implants for much better accessibility. When you're using the 3DDX kit, you'll be provided with this kit right there. It comes with fixation pins, a guided fixation drill, tissue punches, which will not be used here since we're doing bone reduction. The flap will be wide open. And you'll have 30 drills ranging from 50 millimeters length to 28 millimeters length. And the diameters go up from 2.0 to 4.2. You have two double-sided keys to be used with the first 4 diameters, while the 4.2 millimeter drill goes in directly into the RP or the regular platform sleeve, while it's not recommended to use it with the side opening sleeves. 3DDX does not only cover the 3DDX guided kits for drilling sequence. We also work with various generic guided kits in the market, and I know you guys like to use Versa. So good news is very soon we're going to be switching over to the generation 2 of the Versa guides. Dr. Barakat, I believe you're one of the Versa fans, so I guess that's going to be very good news for you and the team.
Yeah, this is fantastic. I didn't know you guys have that already, so that's fantastic news. We're teaching our doctors everything. Versa is one more tool that they can use when they do their osteotomies and their sinus bumps. But it's good that 3DDX is now compatible with VersaVerse, so that's awesome.
Yes, sir. We've been a certified lab with them, and actually through our feedback from all of our esteemed clients and KOLs, we were able to help them change their sleeve system, and this will be the new design. So please
spread the word.
Yeah. All right. Number 4 would be a fully guided implant placement surgical guide. And with this type of surgical guides, we would have the confidence to place such distally inclined implants to that proximity to the nerve canals and the mental foramina. This here is a BLX implant planned with a Straumann Velo drill system, guided kit. And actually here we plan the distally inclined implant just at the minimum from the mesial loop, which is 2 to 3 millimeters. We wouldn't have had such confidence with any other type of surgical guide that does not allow for implant placement. So here we do. Again, here's the Velo drill system. And I know you guys are Knee-Dent fans, so this is also the Knee-Dent Easy Guide system. We're also compatible with it. And the old Knee-Dent GM kit, we can work with both. And also, this will allow us to proceed with a very predictable implant placement. This is the most accurate and predictable of them all. If you do use this type of surgical guides, if your implant allows for guided implant placement, you will not only have control on the implant depth, but you will also have control over the implant timing, which is crucial whenever you're planning for a prefabricated restoration with angled multi-unit abutments. This is how the implant surgical guide looks stacked on top of the foundation or the bone reduction guide. This one happens to be compatible with the BiHorizons guided kit. And here you can notice the magnets fully flushed together. You have also distal legs that are flushed into their components or negative components in the bone reduction guide. As we mentioned, if you use a type 4, fully guided implant placement surgical guide, you can order your guided full mouth restoration or Magnetix GFMR. This is allowing for predictable implant placement using the Magnetix ISG, predictable immediate temporization whenever it's clinically appropriate to load the implants. You want to make sure to follow all the biologic and mechanical recommendations when it comes to the implant insertion torque and stuff like that. And this will also allow for less steps for the final restoration by using the clear duplicate. The clear duplicate will be the same anatomy of this restoration, printed in clear resin, and it will act as your verification jig. And before you start or before you order a Magnetix GFMR case, our 3DDX team will send you a list of all the materials and tools needed for the prosthetic delivery part during the surgery, such as self-cure injectable relining material, like chairside from Zest or Quick Up from Boco, light cure flowable composite to be used chairside for the filling of any gaps after picking up the cylinders in the mouth, Teflon tape, articulating papers, Vaseline to be put on the intaglio surface of your PMMA to avoid any additional material sticking, and it makes it much easier for you to remove any flash on the intaglio. You'll also need a straight hand piece together with denture polishing material and tools. Before we move up to our case studies, please allow me to take any questions. Seems like we don't have, so let's go.
Yeah, I don't see any questions yet in the box.
Yep, so let's go ahead and check our cases. So case number 1 is a fully edentulous case presented by Dr. Paige Barden. And here, this was the initial design on the software. We used 4 implants for an all-on technique. And this happened to be compatible with the Han guided surgery system, I believe. This is the clinical story of the patient. So we have the Magnetix bone supported PPG. Usually you would have some inspection windows so that you can make sure the top part is well secured on the crestal bone. And once assembled to the bone reduction guide piece, they work together as a one unit. You will put this combination inside the patient's mouth, drill and pin, drill and pin, drill and pin, drill and pin, and that's it. You will then remove the top part to be left with any bone sticking outside of the bone reduction window. Now, it's very important to correlate this to the treatment plan. Make sure to double check how much bone is sticking out, and don't feel afraid if you can see more bone in the mouth than we planned for, because usually CVCT scans would show a bit less bone, especially with a low density maxilla like this. After the bone reduction is complete to the level of plastic, this is what we were left with. And as you notice, our surgical guides, our bone reduction guides, do not have palatal flanges. You will just need to do a very simple horizontal mattress suture on the palate to put the palatal tissues out of the way. The next part will be the implant surgical guide. And once you put this in place, you want to make sure to double check for any elevation on the magnets. You'll have 3 magnets, all of them should be flush at the same time. Not only that will help you to assess the seating of this implant surgical guide, but also if you look at it from an occlusal view, you'll notice there are 2 distal legs or 2 distal arms. These distal arms have to be flush in their place. And if they are not, please remove the implant surgical guide, double check the areas of interference, and reduce these before commencing with your implant surgical guide usage. If you use the implant surgical guide while it's not perfectly seated in place, so you might end up with your implants in a bit of a different orientation. And if you ordered a GFMR, this would mean you'll need to do more chairside adjustments for the restoration, for the pickup, and in order to equilibrate the bite. So everything looks good inside the mouth. Dr. Barden finished his reduction and put in the implant surgical guide. We can notice the 2 distal legs here and there. And also we can notice the magnets all are flush at the same time. This is how we planned the case, and this was just a simulation for the bone after reduction and where the implants platforms should be. And this is what happened inside the mouth. This was a perfect replication for the treatment plan, but here Dr. Barden decided not to load these implants. He just opted for a two-stage surgery. Case number 2 is a beautiful representation by Dr. Apolinar Madrigal. And this was the initial situation. So the patient was presented with his upper teeth having generalized spacing, a little bit of periodontal loss right there, and some missing teeth. The plan was to extract everything, reduce the bone, and have 5 Needent GM implants placed. And this one happened to be compatible with the Needent Easy Guide kit, as we notice the very unique sleeves. Same thing goes here. So do not be afraid to open a flap. Now the palatless surgical guide eliminates the need for a big flap as before. So just enough to put in the implant guide and to be able to reduce the crest of the ridge. And here we can notice there are orientation indicators because actually all of these 5 implants needed angled multi-unit abutments. This will be colored in the surgical guides whenever you order a GFMR. Yet, these indicators will be available on all of the 3DDX implant surgical guides that allow for such indexing. But especially with the prefabricated restoration cases, you want to make sure to follow the implant timing with these markers. And the screw access hole of the MUA, of the angled MUA, should be aligned to the distal right there, so that the MUA corrects the distal angulation to a more mesial one. This is the bone after reduction, and implants are in place. Now, another tip is that the bone reduction guide only helps you do a plateau of the bone, and you might still need to do some crestal bone profiling at some sites in order to eliminate any interference between the full seating of the MUAs and the implants platforms. This was the plan ahead of the surgery, and notice on the next picture how we ended up after the implants placement and MUA insertion. I believe here we have almost an identical result, and I want to bring your attention to the orientation of the screw access holes. They have to align to the predetermined markers on the bone reduction guide. Sometimes, which is not very common, we will need to send you an abutment orientation indicator guide. But most of the times we would be able to indicate the markers just on the same bone reduction piece. There is no need for an additional piece to determine that. Now, once the treatment plan has been complete or the implants are there, the abutments are fully inserted without any interferences, we will go ahead and try the passive fit for the restoration. And here they fall in place beautifully. There was no need for any chair side adjustment for the pickup holes. And from there, we can have a look at the pre-planning wax up for this case, which will be also stacked, or which was also stacked as we saw in the previous picture on the bone reduction guide. And this was actually the post-operative treatment planning compared to the pre-planned positions, which are in red right there. So this shows a very decent result, almost in the planned positions, more or less. This is pre and this is post. And as you notice, we have a beautiful smile transformation. Case number 3 is a more complex surgery. Actually, this one is a double arch, full arch surgery and rehabilitation at the same day by Dr. Daniel Van Gelder. And this was the initial situation. As you notice, the patient came in with terminal stage dentition on both the upper and the lower arches. So serial extractions were planned. And this is how the upper arch Magnetix teeth PPG plus the bone reduction guide looked like. This is the lower arch Magnetix PPG along with the bone reduction guide. This is clinically the upper arch after full arch flap reflection, which was completed after the lower arch. And we will focus on the procedure steps of the lower arch. Now, what we can notice here from this picture, I want to zoom in and actually focus on a couple of things. So number one, the fixation drill has been broken. So a great tip is that you don't want to exert any lateral pressure while drilling for the fixation pins. You want to have it as passive as possible because this is not very uncommon. People do exert lateral pressure for difficult accessibility or for any other reasons, and they end up breaking their fixation drill. Here, Dr. Van Gelder was smart enough to keep it as a fixation pin, but you may face some issues while removing this drill at the end of the procedure. So better not do it. Now, also, we want to look at the magnets, and I can see a slight elevation in the magnet on the patient's right and on the patient's left while it's fully closed right there. If you can see this clinically, please stop at this step. Do not proceed, and make sure to clear any interference between the flap, the soft tissue, and the bone reduction guide, because most of the time, this is what's holding you up. You want to have the two distal arms of the bone reduction guide seated on the crest of the ridge. At the same time, the Magnetix part of the PPG, seated on the teeth. And we also came up with an alteration to this design by always having a distal leg right there to reciprocate any anteroposterior rotational movements of the guides while drilling. So here, we should expect that since the guide was not pinned in exactly the proper direction, there was a bit of a discrepancy. So we may anticipate some adjustments to be done at the end of the procedure when it comes to the pickup. And this is what actually happened. So once the guide is in place, the bone reduction guide, you will proceed with exodontia or full arch extractions. This is the arch after extraction. And as you notice, we would have lost this plate before we even notice it if we open the flap before extraction of the teeth. But we were able to keep it, and then we lost it at this step, which is no big deal. We're going to reduce all the bone above the level of plastic anyways. This is it from a top view. And this was our implant treatment planning. This is also knee dent and knee dent easy guide compatible. And this is how it presented in the mouth. Notice again, the little bit of elevation on the patient's left side. And if this is the case, please make sure to go ahead and refine your bone reduction, especially at the two distal areas and wherever you can find any interference between the implant guide and the bone after reduction. Talking about these corners right there. This is a bit tricky, but you want to trim it all before you see the next part. Implants were inserted through the surgical guide. MUAs are in place. And here we had only a couple of multi-units which were angled. The 3 anterior were straight, I guess. And this is our pickup procedure. We will send you these plastic plugs along with the package, and also these plastic blockouts in order to block out any material that can go to the intaglio of these abutments, and it would make it a very unpleasant scenario of locking everything together. You would have to remove the bone reduction guide and split everything outside the mouth. So please make sure to use these plastic rubber pieces or a rubber dam together with the blockout for the screw access holes. As we mentioned earlier, there was a bit of a discrepancy with the initial pinning of the surgical guide. So Dr. Van Gelder had to trim a bit of the pickup holes in order to make these fit. And then comes the clear duplicate part. So the clear duplicate would act as your verification jig. And after the osseointegration of the implants and during the recall appointment, it makes your life much easier. So you'll be removing the long-term provisional or the PMMA, adjust the fitting surface of the clear duplicate to be free of any contact with the rich tissue to allow for sufficient impression material to be injected at the intaglio. And this will be basically a wash impression on the intaglio of the already picked up clear duplicate at the time of the surgery. So when you receive the components email from 3DX, it will include a duplicate standard of the same cylinders used for the pickup of the PMMA. Please do not skip the duplicate or the clear duplicate pickup, because again, it will make your life much, much easier. You will restore the patient in only 2 to 3 visits. And now, let's go ahead and check. So Dr. Van Gelder used the clear duplicate in order to redo the lower arch, as he wasn't very happy with the immediately picked up restoration. And as easy as that, he was able to get just screw access hold, no pickup holes, just a screw in a long-term provisional restoration from his lab. And that's how clean it was. This is the start situation on the upper left. And this is how the patient presented after the treatment and bite equilibration, and also redoing the lower arch. As we saw, we planned for real and accurate results. Magnetix is here for full arch effective treatment planning. And actually, this upper picture was from a live surgery where 5 implants were planned and placed on the lower arch using BLX system and the Velo drill system by the great one and only Dr. Todd Engel. So yeah, please check our website and call us to learn more. With that, our presentation is concluded, and please type your questions in the Q&A section. Dr. Barakat.
Thank you so much, Dr. Safwat. This is very, very, very informative and impressive. Great tips, great sequencing, you know, and I had a lot of questions and he answered most of them as you were talking. So it has a learning curve. So one question comes to mind is a doctor doing this for the first time and wants to use your, you know, your Magnetix design technology. How do you walk them? I know we design everything together. If they want to, do you have like a step-by-step, for example, video to put the pins in, the fixation pins? Or well, how do you walk them through it?
Well, actually, it's a part of our online review sessions with our treatment planning team. We are, I mean, safe to say we have the biggest doctors treatment planning team across the world. We have more than 60 dentists planning your cases, and the team is growing. So this will be totally covered in your review sessions, or if you have any questions, whenever you receive the guides before the surgery, even during the surgery or post-surgery, we are here to help. And also along the package, you will receive the print plan, and whether you ordered a Magnetix GFMR or not, with the Magnetix GFMR, of course, you will receive a separate document with very detailed instructions from our restorative team with, I mean, hands-on steps for the Magnetix pickup. Also, we have a clinical assistance service if you want to order this and pre-schedule. One of our team, our certified dental technician, will come to your lab and help you with your first case, which we very much recommend. If your case is not for a GFMR, it's only Magnetix surgical guides, please be assured we will not leave you like that. We will always send you an instruction document. Right after the print plan, you will see screenshots from your actual case and a detailed instruction on how to use each piece of these components.
Wonderful. That's great. Because I know a lot of doctors like, okay, this is new to me. I want to do it, but I want somebody to hold my hand just the first time I'm doing it. Or so that answers that question. What's the turnaround time from the time we scan and send you everything to the treatment planning phase and the review?
Yeah.
To delivery? Like if I have a patient who wants to do it, like I have a case today that just walked in. Mm-hmm. And he wants to do it next week. I'm gonna do it free-handed, but with a multifunctional guide. But that's the way I do it. That's not what I recommend. across the board. But say, what's the turnaround time if there's a rush case or a normal case?
Yeah, well, normally we take 3 to 5 business days to accomplish a Magnetix guide case, not involving guided full mouth restoration. But for full mouth restoration cases, our minimum is 2 weeks ahead of the surgery. And we want to have these 2 weeks from the time we have all the reliable data assembled on our softwares. If we receive any mistaken or any non-reliable data, we will hold the case, and of course we'll let you know in order to agree together on how to proceed with this case. So 3 to 5 for any Magnetix guides only, and 2 weeks as a recommended turnaround time for guided full mouth restoration cases.
Awesome.
I have another question here in the Q&A. So do you plan to offer hands-on training? Can you give an idea of the cost of an OLON case like case 3? Well, actually, if it's a Magnetix GFMR case, we have a prepaid package. I guess it's $275, I'm sorry. And the regular price would be $3K. Unfortunately, we do not offer hands-on training at the moment, but we are planning for this. So please stay tuned for 2023.
I think that would be a great idea for those who do full arch cases or even simple cases. Whenever you guys have it, I'm sure Greg will let us know. So we can, those doctors who want to get trained, that would be great.
Yeah, so yeah, absolutely. These are great questions too. And, you know, going back to the first question you asked, Dr. Barakat and Dr. Safwat, thank you so much for all the information. You answered it absolutely correctly. So many of our clinicians that are doing what I would consider, you know, not necessarily like the basic cases, just like a single posterior, but are doing some of the more advanced cases and are seeing these full mouth rehabilitation cases, whether it's a full arch, you know, fixed and want to do a full arch fixed case, you know, the assistance that they receive from 3DDX, you know, having the treatment planning and then having our chairside CDT flown out and to do their first cases, we see this all the time. And as far as courses that we actually put on, 3D Diagnostics puts on, the answer to that certainly is correct, that Dr. Safwat has shared. However, we do support other courses and have this type of technology being used in courses. And so one of the cases that Dr. Safwat showed was by Dr. Engel. And so the Engel Institute in Charlotte, North Carolina has 4 courses a year specifically on arch rehabilitation and uses our Magnetix guide, and it is full arch rehabilitation. Some are, you know, tooth-borne guides, and some are bone-borne guides, and, you know, all different variables that Dr. Safwat has shared. And it's an entire curriculum from, you know, from the very beginning of their M1 program all the way to M4. And M4 is the full mouth. It's exactly this. Some are GFMR, but some are just fully guided with Magnetix, and then it's a denture conversion. And everything in between. So it's the Engel Institute, and we've partnered with them for many years and supported them. So it's not necessarily a 3D diagnostics course, but it's the Engel Institute, and they're using our technology for guided surgery in their courses. So if you're looking for some more information, absolutely, I encourage you to look up them, and I can put that. I think I have access to the chat box. I do. So let me
you know what?
here.
I think we might want to chat offline to create something.
And we can certainly do that too. Yeah, absolutely.
Yeah,
yep.
That's another way I'm thinking about it. My wheels are turning a little bit. Maybe we should do a Guardian, you know, guided surgery course and fly doctors over to one location and have a few cases lined up, and we can do that. So we can partner
certainly
with you guys
yeah,
to do that.
and we would love to be able to put that together as well and do some live surgery courses. For sure, and partner with Neodent and do that as well.
Yeah.
Absolutely, for sure. Yep.
Yeah. So that's something that we can take offline as an initiative, maybe that we can do next year.
Yep.
I love it.
For sure. Be happy to put that together.
Yeah. Docs, any other questions? I know it's 7, and I want to make sure that if you have any questions, you can ask. We have one just came to the Q&A here. Hi, can you please explain again how multi-unit abutment positioning worked, especially the angled MUA?
Yeah, happy to answer that. So actually, with the surgical guide, the implant surgical guide itself will help you to align the implant to one of the 6 axes or 6 facets of the hex. And then when it comes to placement of the MUA, you will have another orientation indicator. And this is exclusive to the pre-planned or the prefabricated restorations. So as we saw in Dr. Madrigal's case, we were able to color the flat sides where you should insert the MUA and direct your MUA screw access hole to the posterior colored indicator. If you do that, you will make sure that the 30 or 17 degree multi-unit abutment will correct the angle from a distal towards a mesial aspect for a good pickup withdrawal with the anterior implants or with any other implants. I hope this answered the question.
Dr. Markowitz, did I answer your question? I think it's yes. Yep.
We'll take the wow as a yes, absolutely.
We'll take it, yeah.
Yeah. And so in the interest of time, and thank you, Dr. Barakat, for keeping an eye on the clock for us all. So thank you, everyone, for attending tonight's CE webinar on understanding the Magnetix design technology. Thank you, Dr. Safwat. Thank you, Dr. Barakat. The recording for tonight's session, again, will be available through your education partner, Kim Grensevich, in about a week's time. Additionally, a link will be sent to each of you within 5 business days from our marketing team, instructing you how to be able to receive your CE credit for tonight's program. We thank you again for your time and attention. And lastly, we at 3DDX appreciate your business very much. Thank you so much and have a great night.
So much. Thank you, Dr. Safwat. Thank you, Greg. Appreciate it.
My pleasure. My pleasure.
Great presentation. Thank you. Have a good night.
See you later, everyone.
Take care. Bye-bye.